I want to start by introducing myself. I'm Angela Cummings. I'm the executive director of our AFSP Illinois chapter. And we actually have a few board members in the room today, and I want to introduce them as well. We have Ann King here at this front table. We have Meg Graff. She is our board secretary and also the coordinator for the Research Connection program for our chapter. And we have our board chair, the esteemed Phil Martinez, up here at the front as well. So thank you to these board members for coming. So I want to say thank you all for coming to the Research Connection. Research is such an important part of what AFSP does. You may have heard me say this before, but you're going to hear it again, and you'll hear it every time I talk. AFSP is the single largest private funder of research in the world. That means no other nonprofit is doing as much research into suicide prevention as AFSP. And I will say that Dr. Glaynker, our esteemed guest here today, has been working with AFSP for a really long time. So if you got the reminder email, you'll see there's a link that you can click on to learn more about all the work he's been doing. And one really interesting thing about that link is that you'll see some articles with him, some research that he's done going back to 2015, when he first received, I believe, the first Focus Grant. And the Focus Grant is like the big guy at AFSP. This is the big grant that's over 3 years, that's over $1 million. So it's really for groundbreaking research, and he is a two-time recipient of this, this grant. So obviously he's a huge friend to AFSP, and his work is groundbreaking, and I know you're going to really enjoy this talk that he's going to give. But I also want to point out that if you do go to afsp.org research and you search for Dr. Glaynker, you'll find different articles about his research, and you'll also see a nice age progression. So you'll see Dr. Glaynker with no facial hair, and then you'll see him about 3 years later looking a little bit older and distinguished with a little bit of facial hair. And then you'll see the current version of Dr. Glaynker that you saw that we send out with the promotional. So anyway, he's grown up with AFSP, I guess you could say, as have I. So we're very, very happy to have him here. I'll give you just a little bit of a bio about him in case you didn't read it, and then I'll introduce Meg, who will talk a little bit more about the importance of research, and then we'll get right to it. So, Dr. Glaynker is a psychiatrist, clinician, and researcher with over 30 years of clinical and research experience. Currently, he serves as the Associate Chairman for Research in the Department of Psychiatry at Mount Sinai Beth Israel in New York City, and holds the position of Professor of Psychiatry at the ICANN? Is that how you say it? School of Medicine, ICON. He is also the founder and director of the Glaynker Family Center for Bipolar Disorder. His suicide prevention research focuses on the development of the suicide crisis syndrome and the narrative crisis model of suicide, frameworks that aim to better understand, predict, and treat imminent suicidal behavior. His research has been funded by NIH and, of course, AFSP over the years. And he has published extensively on suicide prevention, bipolar disorder, and the role of the family in psychiatric treatment. So again, we are so grateful that he has traveled all this way to Chicago to give this presentation to us. We're so thankful. So at this point, I'm just going to pass it over to Meg, our board secretary, and our Research Connection coordinator, to just give you a few brief comments, and then we'll get right to the good stuff. Thank you.
Hi, I think many of you have heard me say this before, so I'm going to keep it brief. What I really, really enjoy about this event are two things. One is a tangible way where we can show you where all your fundraising dollars go. And the second is I always leave here feeling a sense of hope as with the science is improving, and with improving science, we get better healthcare and better choices. As far as Dr. Glaynker, it's been over a year since my colleagues on the board have been like, you got to get him, you got to get him, you got to get him. So I personally am really excited to see what you have to say today, because I've been hearing about it for a year. All right, please welcome Dr. Glaynker.
So first, I would like to thank AFSP and the Illinois chapter for inviting me here. It's an honor and a pleasure for all kinds of reasons, and also public service. Okay, I like doing these things because it contributes to the cause. And as you hear in my talk, I take suicide prevention personally because I'm both a clinician and a researcher, and also a chemist in my previous life. But first AFSP, and I started working on suicide prevention pretty abruptly in about 2008. And my first grant was from AFSP then. And the first grant was for defining, describing, and understanding acute suicidal mental state. And you hear about it a lot because there was no description, and still there is no diagnosis for it. Although SCS, Suicide Crisis Syndrome, has been reviewed and in the steering committee in DSM for inclusion in DSM. So it's been great working with the AFSP, particularly because I'm not a career researcher, okay, and I'm actually a career clinician. And I'm very kind of strange, kind of odd bird in that respect because I'm exactly 50-50, which has become increasingly difficult. And that's why what you hear today, it's actually not theoretical research, but this is something that I've seen in practice probably hundreds of times, thousands of times, which has been validated with suicide prevention with scientific methods. And I also have a special connection with Chicago in two ways. So I was a professor at Purdue, professor of chemistry at the time, in 1982, I believe, 82, 83. And I would, every 2 weeks, I would get into a car and drive 3 hours to Chicago, okay, because that's the only way you could really connect with something which is similar to New York, where I'm from. And I had a great time in Chicago, and these like endless trips to drives through cornfields were incredible, still in my memory. And the second connection is that our method was implemented for the first time hospital-wide here. Okay, it was implemented by Dr. Fred Miller, who was the chair of psychiatry in University Health System, North Shore University Health System, and they actually introduced our work and our method, and you'll hear about the results. Here we are, that's Mount Sinai in New York, and this is where the lab is. Actually, it's in 2 different places, and the research was supported by the American Foundation for Suicide Prevention and NIMH, and I have no conflicts to report. My acknowledgements go to both institutions and also to many, many people who worked with me on this, both paid and unpaid. A lot of volunteers are here, as well as clinicians. The scope of the problem in the United States. So this slide is in particular to remind me how long I've been doing this and what happened to the suicide rate in the United States during that time. So in 2010, when we published our first paper, it was 38,354. And then it climbed by 2-3% per year till 2018, with 2017 being a particularly difficult year. Then, not unpredictably, actually, during COVID, the suicide rate dropped, okay, because during calamities, our fight-or-flight responses kick in, and we want to survive. And then once the pandemic ended, the suicide rate continued to climb, and now it's the highest rate ever. So when we talk about suicide prevention, you can approach it in many ways, and one of them is first you ask who is at risk. I mean, who is there? And second, that person is at risk, it's when. Okay, and this is one way to look at it, and this is one of the ways we're going to talk about it. I'm going to talk about it today. Well, obviously, if we have suicide rates climbing like this, although there are many reasons for it to happen, and we can talk about it separately, it's not the subject of this talk, there's a problem with suicide risk assessment and prevention. So, and here is in my opinion, the main problem. In the US, in 2022, over 12.3 million people seriously considered suicide. 3.3% of the population, 25% of adolescents and young adults. Remarkably, 25%. 1.7 million people attempted suicide last year, 0.3%. 49,499, 0.0004% of those with suicidal ideation died by suicide. Very few people with suicidal ideation died by suicide. Very few. 75% of people who do die by suicide deny suicidal ideation and the last communication with people who ask them about it, usually clinicians. The majority of people deny suicidal ideation, okay, when they communicate with people. Yet, so by asking about suicidal ideation and making it the cornerstone of our assessment, at the outset we miss 75% of people. There are many reasons why people do not tell you they're suicidal. It's again a separate conversation. We published about it. But the main issue, in my opinion, is that suicidal ideation is a cornerstone of our risk assessment. So think about it. We have in suicidal person who is really suicidal, in a suicidal mental state. Okay. We have a person who is at the worst moment of their life, which is about to end. We rely on the opinion of that person to truthfully tell you what's on their mind and when they're going to do what, and diagnose their state. Would you ever rely on a patient with schizophrenia to diagnose their schizophrenia? Would you ever rely on a patient with bipolar disorder to diagnose their manic episode? Both of these conditions are more benign than suicidal mental state. And yet, we rely on a person in suicidal mental state to tell you truthfully what they are and are not going to do. And this has been our approach to suicide prevention for decades. So that's why, probably the main reason why current suicide risk assessment methods are ineffective. New approaches are needed for suicide risk assessment and prevention, and we need to reassess the role of suicidal ideation in this process. We need to start from scratch. So this is my personal record with suicide prevention as a clinician. So this is a bit old, so it's 34,000 people right now. I've seen and assessed in my life 34,000 people in my clinical work. Of those, about 10,000 were suicidal. Of those people, three died by suicide while in my care. 1 in 10 years, approximately. 9 people died by suicide within a month after leaving my care. So I remember all of them very well, exceedingly well. I remember our last sessions very well. I remember what I said, what they said. One thing they did not say, okay, none of them was suicidal. Otherwise, I wouldn't let them leave my office. The other thing is that I didn't say. So with each of them, I had this gut feeling, if you wish, that something was not right. Okay, that something is not clicking. And I couldn't define it, I couldn't describe it, and I didn't tell them about this. So that my response, okay, was critical, was not really assessed. So, and this is an approach that we used, this framework, all right, in trying to start from scratch and design a new way of suicide prevention. Why I started doing it? I had a conscious reason and unconscious reason. A conscious reason was then Paula Clayton, who was the medical director of suicide prevention at the time, gave a talk in 2009 at Beth Israel, and I asked her, remembering these cases, do you have any idea, does anybody have an idea what happens in somebody's mind, okay, the day before they die, or the moment before they die? Is there a description of that? Is there a syndrome? And she said, no, and there's no framework. That's a conscious reason, because it was a giant gap in knowledge, and I'm a scientist. When I see a giant gap in knowledge, you need to address it. And the second reason was subconscious, because about 10 years before that talk, one of my patients died by suicide and didn't tell me. Okay. And in fact, he was telling me how good he was doing, how well he was doing. And then he was going on a trip, ostensibly, okay, and he went on a trip. And then next day, I got a call from a police that he was found dead in his apartment with everything prepared. And a week later, I got a letter from him, okay, with a gift saying, doctor, don't blame yourself. You're a good doc. I'm just lied to you, okay. And I decided very recently to do that. And, so that's the best outcome. So that kind of stuck with me. at that point, I changed my career. I was a bipolar researcher at the time and started working on suicide prevention. So in predicting imminent suicidal behavior, and I'm working on imminent suicidal behavior because I see people all the time, and I need to do something there and then in my office. We need to understand both acutely suicidal patients and their clinician's state of mind. And it is, what is the syndrome, what is the mental state, okay, that leads to suicide, prevents suicide, and actually what is that reaction that I have, okay, that has not been described but seemed to be the diagnostic. Today I'm going to be talking about this, the suicidal mental state, but we also investigated that. And if you're interested and there is time left, I'm going to talk about that, but only if we have time. And also how to put these two together in a clinical approach. But let's start with what's happening in a suicidal patient now. A different framework. Whatever we do needs to be clinically useful. It means that every doctor, every clinician needs to use it in their work. Okay, otherwise it remains science. It's not applicable. So how do doctors and clinicians think? That's the important part. This is how they think. It's very simple. Their thinking is binary. Our thinking is binary. If you have diagnosis, no diagnosis, you don't treat. If you have diagnosis, then you treat, and there's a method how to treat. And it's literally as simple as that. There's a Diagnostic and Statistical Manual, 5th edition, text edition. This is current diagnostic Bible for mental disorders. This is an example of diagnosis of a panic attack, which is an abrupt surge in intense fear of intense discomfort that reaches peak within minutes with palpitations, sweating, shortness of breath. You probably know all of it: chest pain, discomfort, fear of dying, and fear of going crazy. When somebody has that, we have a diagnosis. And there's a treatment: cognitive behavioral therapy, benzodiazepines, antidepressants. Okay. There's a particular one benzodiazepine. You take 0.5 milligram twice a day. It takes care of all the panic attacks. That's the treatment. So this is our approach. But we need to have a diagnosis for mental state. Then when diagnosis is there and the criteria are met, you have treatment. You treat this mental state goes away. A person doesn't die by suicide. Critical part. There will be no suicidal ideation in that diagnosis. Why is that? Not necessarily because people do not have suicidal ideation, although some never have suicidal ideation before they kill themselves, and I can give you an example of that. But because it's unreliable. For whatever reason, and there are actually two reasons why people don't tell you they're suicidal. One is that they don't want you to stop them for all kinds of reasons, and the other one is they don't know because it's a short-lived state. In working on suicide, on describing the suicidal mental state, we also came up with an important model of suicidal mental process, okay, model of suicide, which is called Narrative Crisis Model, NCM. We researched it, and it's a very useful framework clinically. And also, if you're not a clinician, if you're concerned about a loved one, this is also something that you can use in everyday life, because people talk, okay, your loved ones talk, and you can hear what they say. And if it fits into the framework, okay, you know where they are. So there are long-term risk factors, okay, or chronic factors, if you wish, for suicide. This is something that probably most of you know. It's a history of mental illness, history of attempts, impulsivity, hopelessness, perfectionism, fearlessness, cultural acceptability of suicide as a solution to life's problems. The most important of these is perfectionism, not impulsivity. Impulsivity is actually not that important. The second most important one is probably lack of fear, which is a trait. This is why we have suicides in military and the police. The third most important one is cultural acceptability, because lack of such, or cultural prohibitions against suicide, is the only protective factor that works. Family does not work, but that works. So when people, and lack of moral prohibitions does not work. If somebody tells you, and we ask them about suicide, and as an option, as a solution, and the person tells you, well, I'm an organic matter right now, but when I kill myself, I'm going to become an inorganic matter. Okay, that's the universe. By the way, real story. Okay, that's bad news. Okay, on the other hand, if I kill myself, I'm going to go to hell. Okay, that's good news. That's protective. So this is long-term risk factor. When a person who has these, and each of them is published, and each of them increases lifelong risk for suicide about 2-3-fold, and a person like that is hit with stress, stressful life events, as all of us do, which come in about 6 or 7 categories only, okay, in my experience, and in reality also. When they hit with stress, which is either final romantic rejection, or catastrophic financial failure, or the onset of serious mental illness, or relentless mental illness that doesn't get better, or bullying, okay, or a threat to ego and identity in a career. Okay, when that happens, people who have this long-term predisposition develop a subacute state, which lasts weeks, and that is, we call that suicidal narrative. And this is a life story. All of us have a life story, okay, our own life story, which is called narrative identity, and this is where we come from, where we're right now, how we got here, and where we're going. That life story, which is a perceived story, does not have a future, an acceptable future. That's the most important part. It had where it came from, okay, where we're right now, no future. Typical example would be, and it's perceived goal. Because a person is a perfectionist, they set up an unrealistic goal, or the unrealistic goal is set up for somebody else, okay, for them, parents, or teachers, somebody, bosses, which is perfect family, perfect career, $1 million by age 19, you name it, whatever. And because the goal is unrealistic, they typically do not reach that goal. Okay, and they start failing. And then, in order for them to be happy, they need to redirect to something which is more achievable. Somebody wanted to be an English professor, they need to redirect to being a teacher. Somebody wanted to go to medical school, grades too short, or becoming a PA. Somebody wanted to be a ballerina, age 39, she's not in New York City Ballet, needs to become a ballet teacher, a dance teacher. So if a person cannot do that, not redirect to actually more achievable goals, and by the way, one other thing I forgot, this goal is the only thing that would make them happy. Okay, the only thing. Only being an English professor, only finding a woman with IQ of 175, okay, who is a model is going to make them happy. Only that. Okay, perfect family. Okay, anything. So if that is not happening, okay, they feel defeat, they feel humiliation. Okay, it's a horrible state, and they feel ashamed, and they cannot talk to other people about it. Okay, because they perceive that they're a burden. They perceived themselves as, they don't belong because everybody else is succeeding by comparison. Like an example, let's say somebody has a daughter who is not doing that great, attempted suicide 5 times. On the other hand, everybody else is around her has perfect children. Okay? So she doesn't belong, and she cannot talk. And this is a terrible state, and when they look forward, there is no future that they can accept, because all small alternatives which are more achievable but minor by comparison are perceived as defeat or settling or something like this. So that's suicidal narrative. It's not an acute risk, it's subacute risk. Okay, it can last for a while. So when somebody is in this state, okay, something else may happen. We don't quite know what it is. They develop the syndrome which we described, and I'm going to tell you in detail what it is and how to ask about it. The suicide crisis syndrome, which has 5 criteria, which lasts hours, maximum day or 2. It's a very short-lived state. It's about duration of a severe anxiety or panic attack. And when people are in that state, which is an acute state, okay, then they can kill themselves. So chronic, subacute, acute, suicide. Each of them has very different criteria. So through this talk, you're going to hear the two abbreviations. One is suicide crisis syndrome, which is a mental state, or SCS, and the other one is this narrative crisis model, NCM. Okay, keep those things in mind, they're important. Okay, here is the suicide crisis syndrome. The criteria A, which is 50% of the syndrome, is frantic hopelessness or entrapment, which is patient presents with a problem that they perceive as intolerable, unsolvable. They might describe themselves as trapped, having no exit and having no solution and reaching a dead end. So the way to ask about it, if you're a clinician, okay, is like this, which is this problem that brings you here, okay, to my office, emergency room, or anything like that. Do you see any options for yourself? Can you get out? Is there any solutions? Okay, and if the answer is no, okay, criterion A is met. There are 4 criteria B. The first one, also each of them needs to be met. They have sub-gradations, but only one of them is sufficient to meet the criteria. The second one, the first one is associated disturbance, affective disturbance, loss of a particular affective state, mood state, which is best described as emotional pain, okay, psychic. It's different from headache. It's different from any physical pain. All we manage the same way. And alternatively, it is a state of extreme anxiety, which is people describe as 15 on a scale from 1 to 10, plus some somatic symptoms like changing in skin or usually or something strange that people never felt before. The way to ask about that is that when this problem that you told me about that have no solution, okay, does it give you emotional pain? Is it painful to you? If the answer is yes, then criterion B1 is met. Second, loss of cognitive control. Okay, and people lose control of their thinking, and they feel that they go into a rabbit hole of repetitive thoughts. Okay, of something that did wrong, that can't be corrected, and that gives them pressure. Like I interviewed a woman the day before yesterday on the unit, and I asked her about that, and she said, yes, it's really like this, like my brain is being squeezed. That was her description. She came in with after a suicide attempt. It is different from a panic attack, very different. And so the way to ask about this, this problem that brings you here, to me, that gives you emotional pain, do you have control of your thoughts, or you feel that you're controlled by your thoughts and you can't get out? And if you do, does it give you head pain? That's criterion B2. Criterion B3, disturbance in arousal. People can't sleep. Most of the suicides happen at night. People can't sleep, and the way to ask about that is, does this, what you just described to me, your thoughts that you can't stop, does it happen at night, and can you sleep? And finally, the last one, criterion B4, is social withdrawal, which is manifested by either vagueness or stop talking to close or others about anything. So the way to ask about that, does anybody know about this? What you're telling me right now, besides me. So where does, this is a syndrome. Okay, there are other things like acute inability to feel, let's say, pleasure, but these are the main ones. It takes 1 minute in the emergency room, okay, to assess this. So whether the suicidal ideation fits, it's what's called a modifier. Okay, diagnosis DSM has modifiers. Modifier is an additional condition. So if somebody comes in with suicide crisis syndrome, after you establish that, you ask them about this, you ask them, do you feel suicidal? And if the answer is yes, it does not decrease the suicidal risk. It increases it. But the answer is no. If you have somebody, I'll give you the cases, who comes in after losing their job and they didn't tell anyone and they can't sleep, okay, and they're no bank account and they feel guilty because they're in debt, and they tell you, no, I'm not suicidal because I'm not going to do it to my family, you're going to take the last statement with a grain of salt. So actually, suicidal ideation is already a modifier in several psychiatric diagnoses. It is, for instance, a modifier for or criterion for borderline personality disorder, depression, and various other disorders like opioid use disorder, body dysmorphic disorder can come with or without suicidal ideation. So we just, the diagnosis will fit right in. So modifier increases the risk. Well, a bit of science. This is called network analysis. It's a fancy way of analyzing symptoms. And what it shows you, as well as with many other analyses, that it is one syndrome, it's coherent, it sticks next to each other. The circles describe, actually surround the symptoms that I just described. And if it were not single syndrome, you would have one of these somewhere at the end of the room. Okay, but they're all together here. The most recent study I just saw yesterday by Vikas Menon. He is in India. He studied the syndrome in 25 hospitals in India. Same thing. It's a very short-lived symptom. As you see, so on the left you see a curve of people who are hospitalized and the various scores on the scale, a different scale that measures it. There's a 61-item scale that gives it a more kind of detailed look. As you see, it's a bell-shaped curve at admission, and then 5 days later on discharge, the curve shifted to the left because the suicide crisis syndrome, SCS, resolved prior to discharge. Short-lived syndrome. Once you soldier through this, if you help your loved one to get through this, it's going to come down, particularly with treatment, because the treatment also is short-lived, I mean, very short. Okay, they're in the clear. Now, in contrast, let's say this is trait anxiety. It doesn't change in 5 days. This is state anxiety, which is actually somebody coming in anxious, changes a little bit, but not like suicide crisis syndrome. It's more short-lived than anxiety. This is an interesting slide, just again about suicidal ideation. So there's 61 items in another scale that describes, actually measures the intensity of the syndrome. And what we did here, you see them, how much each of them contributes to the prediction of suicidal behavior. And then you see that arrow up there. And the number one that you see tied with number two is suicidal ideation. Okay. Number two is strange sensations in my body that I never felt before. They're about equally predictive of suicidal behavior. This here is lifetime suicidal ideation. Okay, which is nothing special. So the predictive value of suicide crisis syndrome is like 88%. If you had suicidal ideations, 89%. So who has the syndrome? We're looking in the community because 75% of people do not tell you, and 75% of people do not come to the emergency room. So we had a study, which we actually designed prior to COVID, but implemented during COVID, called it iSpark. It was web-based anonymous survey of high-risk and community participants in 14 countries on 4 continents. And our hypothesis was that we're going to have SCS in the community, and it's going to be associated with terrible stuff like stressful life events that we thought. First, we actually recruited a lot of people, and we're still working on this. 36,000 people participated, 16,000 people completed because it was a long survey. Actually, as you see from probably Canada was not very participating, in Taiwan recruited 4,700 people in 3 days. So a very diverse group of people, very diverse patients, diverse populations, diverse cultures, diverse everything. And so this is what we found. So of those people, 16,000 people, this is how many people in each country met criteria for suicidal ideation, reported being suicidal over the last months. As you see, the rates are pretty high, and it's 25% that we talked about. This is not community sample. Some of it is Reddit sample. So the rate is a bit high. And this is how many people met criteria for SCS. And the take-home lesson here is that there is fewer people who reported SCS than suicidal ideation, by about 2 to 4 times, depending on the country. So it is there, okay, and it is more circumscribed in the community. And this is the second slide. This is how the suicidal ideation and SCS were associated with stressful life events. On the left, there is SCS. On the right, there is suicidal ideation, SI. And as you see, the association was 4 times stronger, 3 to 4 times stronger for suicide crisis syndrome than suicidal ideation. Okay, and also the association was present in every single country, while suicidal ideation wasn't. It's actually pretty scattered. So that means there is this study tells you there is about 10 times tighter association between stressful life events and SCS than with suicidal ideation, 3 times 3. And again, it's universal. The thing about suicide crisis syndrome, and I did a lot of research in my life, in various areas, it is the only thing that you can, describe it, throw it against the wall, pick it up, throw it against the wall, and it's going to be exactly the same thing. Okay, not a single study failed. So which stressful life events are associated with it? So this shows you that SCS is strong, the same thing that I showed in the previous slide. What's important here, it is during COVID, it's the relationship stressors and threats to role and identity that were associated with it, and not, for instance, threat of harm to others or threat to personal safety, which is COVID symptoms, okay, which were not associated with suicidal ideation. We actually published a couple of other papers about it that maintains the least stressed people, by the way, and the least suicidal people during COVID were essential workers. Is SCS transcultural? Yes. This is where we studied it, and it's the same 5 factors everywhere, except in Korea there's also 4 factors, but basically the same thing everywhere we tried. Now, more importantly, and most importantly, is SCS treatable? So you diagnosed it. What do you do? Okay. It is treatable because there are 4 neurotransmitter systems that subserve, hypothetically, this needs to be now proven because we haven't yet, that subserve different aspects of suicide crisis syndrome. For instance, frantic hopelessness and emotional pain is opioidergic system. Okay, so that's why ketamine works transiently, because ketamine is actually a dirty opiate. I mean, I have my own issues with ketamine because it makes people addicted. Okay, once you stop ketamine, then it becomes suicidal again. But it works. But so will Suboxone, for instance. Affective disturbance and insomnia is benzodiazepines and also opiates. They calm people down. Loss of cognitive control is antipsychotics. Actually, the SCS is a psychotic state. People cannot think straight. Everybody who works with suicidal patients knows that when in this state, you cannot talk sense into them. You cannot tell them that there are other women. You cannot tell them that there are other careers. You cannot tell them, they don't hear you until you treat the syndrome. And so these medications work, and the research goes underway right now, including in our group, to show exactly how much and whether you need 1, 2, or 3 medications, which are already on the market. Okay, you just need to administer them at the right time. The suicidal states at the moment, suicidal ideation, and I'm going to get to it in a minute, is being treated with SSRIs, antidepressants. Antidepressants do not work acutely, okay, in 1 day or 2 days. It's a short-lived state. Moreover, antidepressants acutely make people worse. When you start antidepressant, people get more anxious in the first 2 days. So I can't tell you how many people in the emergency room came in either after starting one of SSRIs or after stopping SSRI, okay, because people go into withdrawal. So it's different medications. So the framework for you, actually, SCS is psychotic panic. So benzodiazepines and antipsychotics are the best drugs for it. So this is who. When? This is Chicago. So Dr. Miller, Dr. Carson, and team implemented this approach in 8 hospitals in University Health System in Chicago, North Shore. And what they did, they abbreviated the scale to the 5 items that I just described to you. Okay, and they used it exactly like this. So the first screening questions were, do you feel trapped? And do you feel overwhelmed, or have you lost control of your negative thoughts filling your head? If somebody says yes to that, or to suicidal ideation, then the full scale is administered, then the doctor makes a diagnosis, and based on yes-no diagnosis, they make a decision whether to admit somebody or discharge somebody. The study was done in the emergency room. Suicidal ideation is also assessed. So first, subjective utility of this approach. And this is, actually was just published. So blue is before they actually used it, just heard about it, and yellow or orange after they used it. So red is neutral. So they felt somewhat positive even before they used it. They thought it would be helpful. But once they used it, they felt even more positive. They found it useful. That's subjective perception. This is objective use. So this is concordance of the diagnosis and action. As you see on the left, that 92% of people who were diagnosed did not have the syndrome were discharged. Okay, I'm sorry, were admitted and did not have the syndrome discharged, and 8% were admitted. Essentially, 90% concordance with SCS. Whoever had SCS was admitted, whoever did not have SCS was discharged. Suicidal ideation actually is 50-50 and was non-contributory to decision making. Okay, this is after a year of use, and in that year there was no suicides in the system. Okay, we're analyzing other factors right now. In fact, the team is working. We're working, helping them analyze the data to see actually if it also reduced suicide rate, but totally changed clinicians' thinking. It works. Okay, how do you? What's going to happen, by the way, and how do you make it available to everybody, other people? The surest way, and the only way, is to make this actually an official diagnosis. What's going to happen if you make it an official diagnosis? First, again, the binary clinician thinking, yes or no. Yes, they treat them. Okay, that's really important part. Second, if it's a diagnosis, a given diagnostic code, like panic attack, that means that doctors and psychiatrists are going to be paid for assessing suicidal patients, and they're not right now. Doctors are actually scared of working with suicidal patients because of the risk. This is the optional part of this talk. We may not get to it, but there's a way to deal with this. So 3, it's taught everywhere. It's essentially, SCS is like, choking. Everybody knows choking. Okay, if you know the symptoms and your friend or your kid starts telling you that, I'm stuck and what happened and she left me and, she's the only one for me, or I can't take it because I got fired and there's no other job, okay, and there's no solution, I can't sleep, this is going to perk you up. So it makes, and then if it's taught, okay, if there are codes and people are paid for it, and then there is more research and maybe more medications. So, and if this is implemented in kind of my estimate, it will save 10,000 lives in the United States yearly. How? 75% of people do not tell you that they're suicidal. This will identify them. If half of them, of those people get treatment, preventive treatment, and prevent suicide, okay, you get 10,000 people. Facilitates, so as diagnosis facilitates clinicians' decision making, improves communications between clinicians, reduces dependence on self-reported suicidal ideation, which undermines clinicians' decision making. Clinicians can use their clinical judgment again, which they can't use with suicidal ideation. They may think somebody is not suicidal, but if somebody tells you, I want to kill myself because I don't have my cell phone, which, by the way, may be a real risk for adolescents, but nevertheless, they would use their judgment and what that means. And again, insurance, medical research. So this is how it works in clinically. This is New York and probably Chicago emergency rooms, and CPAPs and EOB beds are full of these people at the moment who cannot be discharged. After a fight with her mother, Alice, 14-year-old, disappeared and left a note saying, "I can't stand this anymore. I hate my life. I do not want to live." The mother called Alice's therapist, who recommended immediate ER visit once she was found. Moments later, Alice's father called to say that he was currently with Alice at a restaurant. Although Alice was calm, her mother insisted they go to the emergency room. The father agreed. To the ER psychiatrist, Alice explained that living with her mother was unbearable and she would rather live with her father or she would kill herself. The ED psychiatrist did not believe that Alice was in danger, yet admitted her, because he didn't have this feeling that I described to you, admitted her based on the note and because she experienced a breakup a week prior and because also he was instructed by administration to admit everybody with suicidal ideation. So Alice does not meet a single diagnostic criterion for SCS, not one. She's a clear solution living with her father. She does not feel trapped. There is no loss of cognitive control. She is not over-aroused. She is not withdrawal. She's talking to everybody. SCS ruled out. She could be discharged to her therapist. This is the opposite case. A 55-year-old, after losing his job, made 30 calls, 10 of which were to the same person. Martin's wife found him shaking, holding his head and repeating, "My head is going to explode. I don't know what to do." He refused to tell her why he lost his job. The wife got scared and brought him to the hospital. There was no psychiatrist available for several hours, so the ED physician assessed Martin. Martin vehemently denied suicidal thoughts or plans. However, felt trapped in an insoluble problem that he was desperately trying to solve. Lost the job that he couldn't tell anybody about. Showed extreme emotional pain over his job loss. Had loss of cognitive control with pressure in the head. Was visibly agitated, okay, and did not share the reasons with anyone. He was discharged because he denied suicidal ideation. They couldn't admit him against his will, and he jumped after discharge. These are the type of people you would find out and you would save. In conclusion of this part of talk, SCS is prevalent, it exists, it's transcultural syndrome, has been described, replicated. It is much stronger associated with stress and anything else that we see than suicidal ideation that cannot be relied upon and needs to be used clinically as much as possible, needs to be in DSM. So we applied, okay, actually twice. We applied 2 years ago. We got the syndrome back with suggestions. We and more publications. So we published, which replied to the suggestions. By the way, to give you an idea, the application is 100 pages long with 1,000 pages of supporting documents. Okay, it takes a lot of work. You would imagine it's not easy to change the system. So, but we're working on it. And we're implementing SCS everywhere. Okay, and it is kind of snowballing at the moment, although you may not have heard about it. The AFSP grant, the second focus grant, is to implement it all over Mount Sinai system, okay, all the hospitals, and it's a huge system, the largest in New York. It was implemented in North Shore. It is being used in Rochester. It's used in Norway, Italy, Israel, Slovenia, Russia, and in India, as I mentioned. They just published it. And some of these things we know about, some of these things we don't know about. We're surprised when they're published. We need to add SCS to DSM, but we also need to see how the NCM, narrative crisis model, will help us define risk and approach to suicide prevention. So that's the second part. This is what we do currently. Okay. The type actually is we rely on self-reported suicidal ideation. The severity of suicidal ideation is judged by no ideation, passive suicidal ideation, active suicidal ideation, suicidal intent, and depending on whether it's passive or active, people get discharged or admitted and put on SSRIs that do not work short term. The most dangerous time in a person's life with regard to suicide is the first week after hospital discharge. The rate is 200 times higher than if somebody was never admitted. Admittedly, it's self-reported population. It's the most dangerous time. So this is our current approach. Now, as I mentioned to you, it's possible to die by suicide without ever being suicidal. Here's the patient story. A 40-ish, maybe late 30s woman is working in Columbia Presbyterian Hospital as an in IT. She's in the middle of divorce, and she has an 8-year-old daughter, or 12-year-old daughter, I don't remember. And there's a custody battle. She's distraught, okay, and she's anxious and upset, and because obviously divorce is the second most stressful human condition. And her boss calls her into his office and says that her performance is not the best, and she needs to shape up, and she's being put on probation. She obviously gets more anxious and more stressed. What she does is that she starts working harder and more, and she comes to work, then she leaves at 5, or something like this, and then she gets her daughter, brings her home, gives her dinner, and then at 7, 8 o'clock she goes back for another 2-3 hours to the office, and then comes back and works late, and then comes back, wake up, doesn't have enough sleep. One day she is trapped in a situation, okay, because obviously if she loses the job, she may lose the custody. Okay, it's absolutely terrible. She can't sleep. I mean, she thinks about it all the time and has all the suicide crisis syndrome. Never suicidal. So, and one day she's walking actually across back to the hospital from her apartment, and the way she did, hundreds of times before, she sees a van coming on. Okay, she stops. The van hits her and breaks multiple bones. She survives. That's why I know the story. So she has broken pelvis, broken ribs. She comes into treatment for suicide prevention and tells me the story. Were you ever suicidal? Obviously, I ask her. No, I guess I was, because otherwise I wouldn't have stopped. But I never was. And it's not the only case. So suicidal ideation is not linear, and the whole model of ideation to action is a separate issue, does not work. So in 1987, Ian Fawcett published a pioneering study when he followed up 1,000 people at risk for 5 years, and then recorded when I think 40, 50 people died by suicide, some in the first year, some in the fourth, second or fifth year. And what he discovered is that the criteria for people who died in the first year were different from people who died in the second to the fifth year. And what we think about risk factors, other risk factors other than suicidal ideation, meaning hopelessness, past suicide attempts, was not associated with imminent risk. It's long-term risk, just as you saw. But what he did, the first person who differentiated chronic risk from acute risk, which are different things. So just to remind you, this is NCM, and it differentiates 3 mental states. Okay. There's a chronic risk, there's a subacute risk, and acute risk. So what do we do with that? Oh, by the way, we made up the model with the support for the model. I'm going to go through this quickly because we ran 2 studies, and we measured all these measures that assess chronic risk, acute risk, subacute risk at 3 time points, at admission and discharge and 1 month follow-up. It was 220 patients on the inpatient unit. We used structural equation modeling to see what goes where. And structural equation modeling showed us that it actually works just as we described, meaning there's chronic, leads to subacute, which leads to acute. It is now evidence-based. So it was the only study actually to assess a multi-stage model that works and actually gives a temporal support to the temporal progression. Chronic risk is there, then narrative, then crisis. So supported narrative crisis model, replicated suicide crisis syndrome. Narrative, by the way, is very important. The narrative that I described to you, meaning life story that goes nowhere, is critical because our emotional response, if we get to that point, is actually not to the crisis, not the personality, but to the narrative. We respond to the story. And for those of you who work in the system, you know that our current electronic medical records discourage narrative. It's drop-down menus and checklists. 90% of time is being spent on drop-down menus and checklists, which basically fragments the story. You can't. So that actually probably also contributes to poor assessment. So we need kind of to temper our enthusiasm for this. And we need to use NCM clinically to prevent imminent suicide and also as a framework. And here the first time I'm saying is that a staging of suicidal mental process like we would stage any medical illness, as we do, and I'll show you how that would work. So first, somebody comes in an emergency room where you have somebody who is suicidal. How do you use the NCM model in terms of designing your treatment? Well, somebody comes in, the first thing you do is means restriction. Example, family drives to New York from Ithaca, Cornell. There is actually a couple who is having marital problems. A lot of violence in the family, 5 children, 1 in jail for murder, 1 for assault, and the guns in the family. The woman who actually drives, because the wife who is disturbed by what's happening in the marriage has 3 loaded guns in the house. Okay. So the first thing you do is you take ammo out of the guns, okay, and separate them. That's the first thing you do before you do anything else. The second thing that you do is that if she or her husband has suicide crisis syndrome and feel trapped in the situation, don't know how to get out, you medicate the syndrome. Okay, I'm not going to name the drugs because then I'll be kind of bound to drug companies, but you give them benzodiazepines, you give them antipsychotics, and if necessary, you give them painkillers. Then people can think straight after that. After she can actually process the situation, okay, or he can process the situation. In this particular case, actually, it was he, because in the family center, we treat everyone. Then you start doing cognitive therapy, either CAMS or ASIP, on restructuring suicidal narrative into life narrative. Then you can start working on that. People can hear you. And it's kind of a crisis intervention situation. Then, when suicidal narrative resolves and people see acceptable future, okay, then you can start dealing on stress management techniques to prevent future attempts if stress hits. And when that works, then you can do long-term therapy for, let's say, reducing perfectionism, okay, and making people more tolerant of the self and self-acceptance. So this is how you use the model in acute state when somebody comes in suicidal to your office or emergency room. But there's something else. So NCM, again, describes 3 mental states: chronic, subacute, and acute. How do you use it as a framework to prevent suicide in the community? Stages. Congestive heart failure, that most of you probably are familiar with, has 4 stages, which you may or may not be familiar with. Stage A is long-term risk, no CHF. And this is somebody with hypertension, diabetes, and obesity. At some point in their life, they may develop congestive heart failure. Stage B, still no CHF, but somebody may have an MI and has some valvular disease. No symptoms, no CHF. Risk higher. Then stage C, early CHF, shortness of breath, fatigue, reduced exercise tolerance, medications. Targeted treatment medications, nothing drastic, maybe stent. Okay, and finally, the 4th, advanced CHF. This is where you do drastic measures, including heart transplant. Okay, 4 stages, clear progression. So if we use the same approach with suicidal mental processes, you have 4 stages. Okay, I pulled out stressful life events as a separate stage. So somebody with the chronic risk and trait vulnerabilities, perfectionism, no risk. Somebody with that has stressful life events, Okay, no suicidal narrative yet, just stressful life events, no risk. Develop suicidal narrative, subacute risk. Okay, with suicidal crisis syndrome, acute risk. Similar progression. There are targeted treatments for each of those stages. And each of these treatments reduces suicide risk. For instance, in stage A, chronic trait vulnerabilities, you treat long-term risk factors like motivational interviewing for substance misuse, if that's the case, self-acceptance, reducing perfectionism, setting up realistic goals, improving resilience. Okay. If stressful life events, you deal, if stress hits, let's say romantic crisis or work problems or something like this, or financial misadventures, you help people deal with stress if there is no narrative. Okay, how to manage stress. That's DBT, works for that, for instance. Stage C, when somebody is a narrative, you start, although there's no suicidal crisis, okay, you need to work on restructuring the narrative. Okay, back to the life narrative, opening doors. The most important thing when somebody comes in a situation of entrapment is opening doors. Okay, that's the first thing I do. Once the doors are open, once people see the options, risk drops dramatically. And finally, if there's SCS, it's an acute situation, medications. Okay, and then backwards, as you just described. As you see, there is targeted, similar targeted treatments in CHF, depending on the stage, and the treatments are different. Okay, and preventing CHF or life-saving at the end, just like with suicide. So where are we now? Future directions. SCS implementation versus treatment as usual. So we need to show, and this is research, and this is where AFSP comes in, that we're very grateful for, because only research is going to show you that you implemented, suicide rate drops. It actually prevents suicide. So we have, at the moment, a study at Mount Sinai. We have a study in Hungary, in Pech. We have a study in Chile. Okay, three studies are going on at the moment. We have also ongoing randomized control study, which is 1, 2, or 3 drugs, and to see versus treatment as usual, which one is the best combination. And the other thing that needs to be shown is that, because I'm convinced, but there's no research for that. Okay, other people convinced also, is that you need to do medication first and then therapy, not the other way around. Then we need to show that the model works, and actually using it also prevents suicide. Again, that needs study. Staging studies are also needed, because this is so far a hypothesis. And finally, what is needed is doctor emotional self-awareness and management. Okay, because these emotions that I described to you, we define them, we know what they are, we know how to help people identify them. So doctors can use them clinically in their suicide prevention, but this is something, if people have questions, we can talk about that also. But for the time being, let's stop at suicidal crisis. So thank you for your attention. This is the first edition, 2017, when most of what I described to you was a hypothesis. And this is the second edition, just came out, when it's actually evidence-based. Thank you so much.
Hello. Does anyone have any questions?
I have a question. You just said in your last few statements that you absolutely believe it's important that the research begin with medication as opposed to therapy. I think
Not research, treatment.
treatment. Can you explain why you think that and why it's not a combination?
Because when somebody, sure, it can be a combination, but it cannot be a therapy first. Okay, and it cannot be a combination in the first hours because people just do not hear you. They really can't. What could be? I gave you examples. It's like, you know. Let's focus on the second criterion. Criterion B1, which is emotional pain, okay, or acute panic. It's kind of like having a broken arm, okay, or abdominal pain or something like this. If somebody has a broken arm and you try to talk to them, okay, they can't hear you. The only thing they think about is the pain. I mean, once you give them a painkiller, they can hear you. It's literally the same.
Hi, I have a question about, you referenced the pharmacological treatments. Would you consider ketamine and Spravato as the pharmacological
Yes,
treatments?
it is a pharmacological treatment, and it is that is used everywhere. I think it is actually more of a problem. It's one of the things in psychiatry, in my opinion, that should never happen. Okay, and the reason being is that it's a drug of abuse. The reason it's a drug of abuse is because it's actually opiate. It's like morphine, except weaker and dirty and causes dissociation. Yes, if you put somebody who is who is suicidal and in pain on morphine, you're going to blunt the pain and people are going to get euphoric. But then morphine is going to wear off. The pain is going to come back.
Okay,
In the
what
process, you get somebody addicted to morphine.
What about transcranial magnetic stimulation? Is that an option
I'm sorry?
also? TMS?
TMS, I'm underwhelmed with TMS. The Suboxone, for instance, which is a clean opiate and is used for maintenance, is probably a better treatment. I use Suboxone clinically. I'm sorry, I shouldn't mention names, but you know, it's a clean drug. Also, every benzodiazepine works. Okay, antipsychotics work. The antipsychotics work within 24 hours. Many times. It's actually my first-line drug. Treatment is a combination of an antipsychotic in a small dose plus benzodiazepine. Then within 24 to 48 hours, you can talk to people.
Yeah, I just kind of wanted to reinforce what you were saying about like that immediate treatment that the SSRI is not going to provide because it takes several weeks to build up a level in your system or whatever. And just anecdotally, I can relate to that so much. I know of a personal story where the person actually had their anxiety continue to go up because they had started taking the medication and they were like, why am I not feeling better? And they said, it's not going to work. Because they didn't start feeling better within that first week, they thought, then this is not going to work and then there's no hope for me. And it actually increased, in my estimation, it really increased the risk even once they started that SSRI because
you're absolutely
they
right.
thought, it's not going to work for me, I'm a hopeless case. So I thought that was really interesting because I know that if you do end up in the emergency room, they're going to send you home with a Lexapro prescription and maybe nothing else. And so I really just honed in on that, what you were saying, that something to patch through until that Lexapro or whatever will kick in. But then are you titrating? Like, are you slowly adding Lexapro?
Yes.
Like increasing and then kind of decreasing the antipsychotic?
Yes.
So that they're
Yes,
kind of
yes.
meeting in the middle and then...
Depending on the diagnosis. Because 50% of people who die by suicide do not have a psychiatric diagnosis.
Right.
Okay. And, you don't... they need to be diagnosed. So you do that, and depending on the situation, you establish a treatment. For instance, the most typical story that I deal with clinically, which is all the time, is the following. And I'm sure a lot of you can relate to that. There's a 23-year-old who is in college, okay, who was doing well in school, started smoking weed at about probably the senior or junior, went to college. College is tough, okay, the mom is not there, the grades are there, not doing well, okay, cannot take it because life was actually relatively easy at that point. Starts smoking weed, actually staying in the room all the time, becomes psychotic from weed. Okay, ends up in the emergency room with ruminations of failure and psychotic. So the treatment here is you need to stop using weed. You give an antipsychotic with the hope that it's actually a transient reaction as opposed to schizophrenia, because cannabis causes schizophrenia. Okay, no antidepressants are needed here. Okay. On the other hand, if somebody comes in depressed, it's a different situation.
I have a question. What do you think the timeline is for getting getting this on the DSM and having it be more prevalent so that the ability for non-medical professionals to be able to leverage the tools that you just covered, because the more people that have the ability to recognize or even non-medically diagnose a SCS. I will tell you, my son died by suicide at the end of June, and he was having all of these at my home, and I let him drive away, and that was the last time I saw him. So if I had known this, if it had been more prevalent and common for people to recognize this, I think I could have at least got him treatment at that point.
I'm so sorry to hear that. I mean, first of all. Second, it is not the first time I hear this. I mean, almost word for word. The timetable, I actually don't know because I just emailed Paul Appelbaum, who is the chair of the steering committee. Okay, and I know that it was reviewed, and the steering committee reviewed the review, okay, and made a decision, and he said, I'll send you an email as soon as I get my hands on it, so I'm waiting. Okay, then I don't know, okay, what's going to happen. Because there is a number of options. First, they can tell me, you're full of it, we're not going to do anything about it. Okay, it's possible. I don't know if you know the story of suicidal behavior disorder, okay, which was sitting as a condition for further study for a while, and then became modified. I think the best current outcome would be actually make it condition for further study. I mean, realistically. Because if it's in DSM a condition for further study, then people start doing it. People start actually asking, and it's going to be researched. But we'll see what happens. I'll be the first one to let you know when I hear from them.
Yeah, I have a question. I was just thinking about what you had said about how we can't really know what's in the mind of a person before they attempt suicide. And I was thinking about how there's one approach where we look at this biomedical model and we see a set of criteria and symptoms. We try to determine who has these and treat them. But I'm also thinking about kind of these formats of different research and how there's so many people with lived experience who have been observing individuals with these experiences, and I'm wondering what you think the role is participatory research of individuals with these experience informing. Because one thing I always think about looking at criteria is like what goes into the selection of these criteria. Do they reflect that experience that we feel is so obscure that is really difficult to determine? How can we really bring in people with these experiences to inform that treatment in a collaborative way and inform our understanding of suicide?
We involve people with lived experience. Okay, they're part of our research studies, and in fact, the study that I mentioned, which is training clinicians, okay, we involve people with lived experience to assess whether clinicians are trained and whether they would come back to them, and if they wouldn't come back to them, why and what needs to be changed. Okay. In terms of reporting the mental process itself, I do rounds weekly with a whole bunch of people, and every time we do rounds, we hear it again and again and again and again, and it's the same story. So it's actually pretty clear.
Two things. You mentioned that medication at some point is not good. Did I misunderstand you, or where it has to be adjusted? That it works against a person?
Yes. There is in two circumstances. A lot of medications, most of the psychiatric medications have a biphasic onset of action. Side effects happen immediately, and the desired treatment happens a while later. Okay. So side effects for a lot of medications, immediate side effects, actually make people feel worse. specifically increased anxiety or sometimes panic, is a side effect that happens immediately. So if somebody comes in and put an antidepressant, particularly by an internist and a family doctor, actually, not a psychiatrist, that's where the problem is. One of the problems is they will feel worse. The other issue, another issue is that you may or may not be familiar with this. Antidepressant withdrawal is brutal, like brutal. This is not something that drug companies want you to know about, but it's as bad or worse than it is from benzodiazepines, like Klonopin and Valium. And so if somebody has been on, let's say, Lexapro for a couple of weeks and stopped it, okay, they're in terrible state. And it's also anxiety and depression, okay, all of it. And it's worse, okay, I can actually describe the syndrome to you, withdrawal syndrome. Is different from the recurrence of the previous illness that people had that's being treated. It's actually different, okay, and it's worse.
One thought is that when a person is suffering with this, it's asking them a lot to have to navigate themselves on their own behalf. So to me, it really shows how critical their family is or another person to guide them, because it just seems so overwhelming. And then if you have a physician or family doctor that is not versed.
Absolutely. I can tell you how right you are in how many ways. First, it's terrible to be alone in this. Really. Second, family helps, and I run Family Center for Bipolar Disorder, which is a very different approach. And the approach is that we actually don't take individual patients. We only take families who sign confidentiality and HIPAA waiver at intake. Okay, so there's an open communication about all the symptoms. And it works a lot better, okay, because nobody's hiding anything from anyone. And it's also the best approach for suicide prevention.
Thank you.
All right, well, thank you. Excuse me. Thank you, everyone, for coming today. Thank you, Dr. Glaynker, for sharing your time and wisdom
thank
with
you.
us. Please fill out the evaluation on your table to help me plan the spring event. And we'll see you all soon.
Thank you.